Good evening, everyone. Welcome to tonight's Lung Cancer Living Room. I am beyond thrilled to see so many smiling faces in the room. Welcome to all of you who are here. We are thrilled to be talking about radiation oncology. It's been a minute since we've had a topic solely focused on radiation therapy. We touch on it a little bit here and there in some of our other meetings, but we are thrilled to have, by very popular demand and a lot of poking and prodding, Dr. Danielle Schiffner here to speak with us, who is obviously a radiation oncologist at Sutter Health and PAMP. With that, we're going to get started. And Dr. Schiffner, I think one of the things we're hoping to do today, not only talk about some of the amazing advancements, but to really sort of lift the veil off of or demystify what might still be some continued fears when people hear that maybe radiation therapy is being recommended as part of their treatment plan. And as I say all the time, regardless of what type of therapy we're talking about, chemotherapy, radiation therapy, clinical trials, that it's not your grandfather or your great-grandfather's chemotherapy, radiation, and clinical trials. Things have, in fact, changed so very much. So before we jump into the role of a radiation oncologist.
So most high-functioning cancer programs function as a multidisciplinary team. The sort of organizing body is typically referred to as a tumor board, and essentially any cancer can be treated with surgery, so surgical oncology, with radiation oncology, and with drugs, systemic therapies, one type or another, and that would be medical oncologist. And then, there's more to the cancer team than just the MDs. There's the cancer nurse, there's nurse navigators, dietitians, social work, dedicated oncologic-focused diagnostic radiologists, pathologists, and these groups come together in tumor board. And at a multi-specialty group practice, like where I'm very fortunate to practice, we also interact constantly throughout the day. And depending on the stage and type of cancer, it can involve the surgical oncologist, radiation oncologist, medical oncologist, or any permutation therein.
So what is the role of a radiation oncologist, like at its core?
It's a very fair question. Some of my best friends still think I'm a diagnostic radiologist, which is a really different field. So, as a radiation oncologist, we treat cancer with radiation. There's actually an increasingly large number of non-malignant diseases we treat with radiation these days as well. But that's what the radiation oncologist does. For cancers that are radiosensitive at the stage where we're called on to treat, that's the service we provide.
So we know radiation therapy is the service you provide. What exactly is radiation therapy?
Yeah. Great question. So, radiation is a word that evokes a lot of understandable, apprehension. But in the context of medical radiation and the treatment of cancer, we're using high energy X-ray beams in the most common context of giving it. That are tightly focused on the tumors, and radiation causes some unique types of damage to cancer cells that actually cancer cells really can't repair. Normal tissues actually can repair that type of damage, and that's how we're sort of able to harness this very natural force of radiation to kill cancer cells. Radiation's a local therapy, so akin to surgery, the radiation beam only has effect and side effect where we aim it, and that's in contrast to what the medical oncologists give, which are drug therapies that sort of work the whole body over.
Yeah, and I think it's an important distinction. And I think as we kind of move forward in this conversation, we're going to talk about why, in a lot of cases, either as a mono or singular therapy, radiation is great, but also how it works in combination with other therapies for even greater responses in some cases. Just for a quick show of hands and no pressure, nobody has to raise their hand if they don't want to, regardless of the answer, but how many folks in the room have had radiation as part of their therapy? Yeah, so a decent amount. Yeah, which is great. And I really encourage you guys, as we're having this conversation, to comment on your experience or any questions you have about how maybe decisions were made, because I think the decision-making process of when and how to bring radiation is I know something we hear through the helpline and folks that are calling us from around the world all the time. Okay. I mentioned earlier, it's not your grandfather's or your great-grandfather's radiation. So I've already sort of set the stage for radiation being different now. Can you talk a little bit about how it's different and the different types of radiation therapy?
Sure. So in the context of lung cancer, we're almost exclusively talking about external beam radiation, which is where we're aiming radiation beams from the outside in, focused on the tumor, lymph nodes, whatever structure we're trying to treat. There's been a lot of advances over the decades. Radiation was discovered in 1898, and within 1 year it was being used to treat cancer. Of course, they had no idea how it was working or how to target it. But over the decades of the 20th century and well into the 21st, we've gotten very good at designing our radiation beams to be very focused on the tumor. One technology is called intensity modulated radiation therapy. Maybe the next generation of that is what we call rapid arc or volumetric modulated arc therapy. But these are ways of using numerous beams of radiation that are focused on the tumor. And that provides, in many cases, a very negligible dose to the normal surrounding tissues and high doses to the tumor, and that's important. We've also gotten a lot better at targeting the tumor. And so, the main technology around that is called image-guided radiation therapy, or IGRT, and that lets us be very accurate and precise in the delivery, and that's especially important when we're giving high doses of radiation therapy. And then in the direction of the high doses of radiation therapy, there's a technique that I have a particular passion for called stereotactic body radiation therapy, or SBRT. Some places call it SABR, but these are synonyms. And that involves delivering really quite robust doses of radiation with literally sub-millimeter accuracy. And in the context of the lung, that requires us monitoring and managing motion because these tumors move. And so that's delivering entire courses of radiation in typically 1 to 5 treatments. So these are a lot of the really exciting developments. There's internal radiation, less of a role with lung cancer. That's called brachytherapy. I think that's a pretty good overview.
Yeah, I think it's great. So just to hopefully prevent any confusion, because I feel like that was sort of a lot. So in some instances, I guess that sort of like in a nutshell, back in the day, whenever that day was, radiation therapy was given. A beam was set as close to the tumor as possible, and this is regardless of cancer type, right? But unfortunately, a lot of healthy tissue was damaged in that process because there wasn't an ability to really streamline and target and pinpoint where the radiation beams were going. And so whether you're talking about IMRT or, a lot of these things, it's similar, it's a different type, but effectively the same outcomes, the same sort of idea.
Yeah, the targeting has just gotten so much better. For one, in the earlier times, the beam design was done on just a front to back x-ray. And so basically they had to put these very large margins to make sure you would cover the tumor, and that really limited the dose you can give safely, a lot of toxicity, not really the best outcomes. These days we use all the imaging modalities that exist in the sphere of medicine. We do what's called CT simulation, so we're using 3-dimensional imaging to target. At our center we use what's called 4-dimensional CT quite often, and the 4th dimension here is time, so we're actually monitoring the tumor moving, so we're not just putting these big margins on, we're tracking the tumor in real time. Sometimes we'll actually have implanted markers within that tumor that we can really lock onto. And then we're incorporating the other diagnostic modalities of MRI in some cases, especially when we're treating along the central nervous system, which is sometimes unfortunately relevant in lung cancer, as well as PET, and really everything in between. Everything we can get our hands on, we're going to use.
Yeah, the technology of using this sort of in real-time imagery to guide, especially because I don't know if it's something prior to me 17 years or so ago entering the space, I didn't give a whole lot of thought to how they might radiate a lung that is breathing and moving. And you set this beam, and then somebody takes a breath because you need to breathe. And then all of a sudden, right? And so I think it's fascinating to me. And I can only imagine how much better this is going to get as we sort of continue through this process.
Definitely.
So kicking back a little bit, sort of along these same lines, can you explain a little bit about the mapping and what that process from the patient perspective might look like?
Sure. So unlike ordering like an MRI or a CT, this really involves a physician consultation. And sometimes those consultations are sort of like pre-screened in the context of tumor board. Sometimes I'm treating patients from a great distance. I'm meeting for the first time and reviewing outside records, but it begins with a consultation. We really need to make sure that the individual we're meeting with is really a good candidate for radiation, that in the multidisciplinary management, radiation really is a sensible tool. And sometimes the answer is no, but typically by the time they make it to me, the answer is yes. Then we have to talk through side effects, and that's going to depend on the volume and sort of where we're treating. But then if we decide that we're going to go ahead, we start with what's called a CT simulation, or the 4-dimensional CT. So the patient's going to come in. We're going to get the patient in the appropriate and reasonably comfortable position, and we have some custom devices and cushions to ensure that. We'll do the scan of the area. We typically make skin marks, which are like tattoos. We're actually rolling out a tattoo-less program at our center, so that's something that we're really excited about. So that's not always going to be part of it going forward. And then from there, the patient part is done. And then from there, we import the treatment planning images into our treatment planning computer. The medical physics staff, and these are amazing people. Like, we work with 3 PhD medical physicists, and the patients never meet these people, but we're really fortunate to have really the best in the business. And they collaborate with the physician in designing the radiation beam, in making sure that the radiation beam that's being designed in the computer is deliverable in real life. That's what's called the quality assurance step, where we deliver the radiation beam to what's called a phantom. The phantom is actually a mannequin with radiation detectors in it to verify that what we designed in the computer is deliverable in real life, and only then do we call in the patient to begin the treatment.
So that's amazing. I mean, you think about all of the sort of triple checking that happens before this type of therapy actually goes to the person diagnosed, which is fantastic. So we're talking right now sort of about treating, I'm assuming from a mapping out and what this process looks like, lung lesions. For brain lesions, it's a little bit different. And I know that's not on here, but I know you know what I'm talking about.
Totally, yeah.
So, but I want to talk about how that is a little different, because I know a lot of folks have had brain radiation and the mapping out and the mask and all that stuff. Mm-hmm. Can you kind of walk us through what that is?
Yeah. So when we're treating the lung, there's no way to like rigidly immobilize the lung because you're breathing, you're swallowing. It's human. When we're treating the head, though, especially when we're giving what's called stereotactic radiosurgery, which is really the approach I favor with brain metastases, we really need sub-millimeter accuracy, and it turns out you actually can immobilize the head. In prior eras, that involved screwing a frame onto the head using a technology called Gamma Knife. We, like most places, don't do that anymore. We actually make this mask. It's made of what's called thermoplastic material. It starts as this like plastic mesh that's flat. When you heat it up, it becomes stretchable and malleable. We mold it to the patient's head. As it cools, it hardens, and that becomes a rigid mold to hold a patient's head in place. Comfort is acceptable, better than screws in the head. And then we do the same CT. MRI is really what you need to see the brain, so we're going to be fusing in the MRI. That's essential. Turns out PET's not that useful in the brain, but it's usually a CT and MRI fusion. And then from there, the steps are essentially the same. And the most high-functioning stereotactic radiosurgery programs do involve collaboration with neurosurgeons. So that's going to involve a different type of surgeon. But a lot of the anatomic considerations that go into stereotactic radiosurgery are very similar to those that go into proper brain surgery. So that's why they're involved.
Yeah, thanks for that. And I know we're going to jump in a little bit later into a little bit more detail from an early stage, late stage, and what that might look like from a radiation perspective. But I appreciate you walking us through that. So how is it determined? Because I know in groups like this and other program areas that go to and others have, people diagnosed are talking to one another, right? And it's like, well, I had this type of treatment or I had that type of treatment. So a lot of times people are like, well, logically you might think, well, I have this biomarker or I don't, or I'm either on targeted therapy or IO or in chemo or something. But you find the similarities, but then something's different, right? Like, how do you determine what type of radiation might be right for a patient?
Yeah, I mean, in broad strokes, it really depends on the stage of the disease. That's what really helped us kind of calibrate the best approach for the given patient. And also with radiation, again, it's a local therapy, so proximity to critical normal structures, like tumors that are sort of plastered against the heart, might need a more thoughtful approach than ones that are sort of sitting out in a field of normal lung. So the anatomic location really matters as well. Volume of disease, stage of disease, nodal involvement.
So there's a lot of thought that goes into it. In other words, I see a lot of nodding heads.
If you have lung cancer, but a tumor is found somewhere else in your body, but not in your brain, is that something you can also maybe radiate? Is that what we're talking about here?
Absolutely, yeah.
Okay.
So actually, one of the most exciting, parts of being a radiation oncologist in this era and treating lung cancer is the real value of treating what are called oligometastasis. So that's O-L-I-G-O, like oligarchy, like few. And so in patients who have like 1 to 3, even up to 1 to 5 tumors that are elsewhere in the body, that's quite amenable to radiation, and that has some very promising outcomes. I'm happy to expand on that now. We could sort of go into it later.
Yeah, I mean, I think, so a lot of folks who are old-timers here, not old-timers in life, but old-timers here, are very, Sally, nobody asked you how old you were today, are very familiar with talking about oligometastatic and oligoprogressive disease. And I think maybe we want to get into it. Well, I mean, I guess we could get into it now. So you guys have heard me say in the past, you're on XYZ systemic therapy. And historically thinking, and I'm just going to simplify this really quick so that he can jump into when and how he best determines, but your systemic treatment is effectively working on 80-90% of your cancer. But you've got these couple little bugaboo spots who are just not liking whatever the systemic treatment is. That's when this guy comes in and does his magic, right? And can hopefully treat those spots so you can stay on your systemic therapy, because historically you'd just come off therapy and you'd switch to something else, right? Because it was considered, nope, your cancer's no longer responding and we have to change your treatment. Am I
Yeah,
close?
that's very well stated. It's sort of the traditional way of thinking about metastatic disease is that if it's moved from the site of origin to somewhere else, that's stage 4. Stage 4 is a systemic disease, should only be addressed with drug therapies like traditional chemotherapies. And you're absolutely right. Let's say there were 10 spots, 9 of them responded, 1 of them didn't. That was considered a non-responder, and then you'd sort of set that drug program aside, never to return to it. That card's been played, and if there were other options, that was good news. But especially if you look back 10, 20 years, there might have only been 3, 4 options, and once you got to the 4th one, that was sort of it. In the current framework, there is this concept of oligoprogression. So again, the same patient, 10 spots, 9 of them seem well controlled with the drug program. And of course, these days we're looking at immuno-oncology, we're looking at targeted therapies, and in some cases chemotherapies. But if only one spot is a bad actor, only one spot is growing, presumably there was just one clone of cells that was able to get some resistance. And drug resistance does not predict radiation resistance. We zap it with radiation, get that spot under control, and the medical oncologist and the patient continue on that same line of therapy, and that can be repeated multiple times. I will say, though, that what if all 10 spots are growing? Then you can really say at that point you really do need to switch things up. And usually we say between 1 to 3 spots, at most 1 to 5 spots, is sort of where we draw the line between oligo-progression and macro-progression.
Yeah. And I think it makes sense, and you guys have heard me say over and over and over again, like, the goal here, particularly with late stage, and we're jumping kind of all over the place in this agenda right now, but is to stay on therapy as long as you can, right? Because we know there might be a second or third line, but we're just waiting for the next best thing. And you've also all heard me talk how exciting the next best things are that are kind of coming down the pipeline. What are some of the exciting things that have happened for folks who were diagnosed with stage 1, particularly those who, for one reason or another, might not qualify for surgery?
As of 2024, people with stage 1 lung cancer, if surgery is possible, that should be a strong consideration. But again, this is a local stage. This is a tumor in the lung of a small to medium size. And actually, stereotactic body radiation therapy, not to be harping on the same thing so much, that's a very exciting, very safe, very effective technology that in time might actually even displace surgical resection. So again, this involves using all the advanced tools that I described earlier, often fiducial markers, which help us track the tumor, all the imaging, the 4-dimensional CT, but giving somewhere between 1 and 5 sessions, typically 3 to 5 sessions, focused just on the tumor itself. These are tumors that have not spread to the lymph nodes, and we treat it. Very well tolerated, 90-95% local control rate. What about the lymph nodes? Turns out that well-staged patients with PET-CT and sometimes other ways of looking, like what's called EBUS, lymph node failure is less than 10%, so this would be considered curative treatment. It does have these sort of blast zones that you have to know how to kind of interpret in the area of the tumor. Sort of referring back to the last question, but this is a very exciting area. That's a real win for cancer medicine. It's a real win for patients with lung cancer.
Yeah, I couldn't agree more, especially for those folks who, like I said, for various reasons, people might not be able to withstand a surgical procedure. And so this is something that provides an excellent option with amazing outcomes. We keep talking about sessions, 3 to 5 sessions. How long is a session? I don't think we touched on that.
Sure. So like the beam on time is usually about 10 to 20 minutes. What could vary is how long it takes to get in the right position. What also could vary is if we're going to be able to treat the patient continuously or actually target the radiation to the tumor only during specific phases of radiation. But typically, some of my patients might laugh because I'm often running late. But like usually like door to door is about an hour. Yeah.
Yeah. Okay.
Yeah. Give or take the Schiffner factor. Yeah.
There's a lot of laughing in the room.
Yeah.
I want to jump now to stage 3. And again, when I think about this from my own personal experience, those of you who have known me for a long time also know my mother, Bonnie Adario, and she was diagnosed at 3B. And I'm not going to get into all of the details around it, but after originally being told there was nothing they can do, she had, and there was pre-targets, right? Like Tarceva was still in trials at the time. Chemoradiation up front, lobectomy, repairs to the aorta, subclavian arteries, and then interoperative radiation, like post-surgery, and she's 21 years cancer-free since then. But I think that, especially for 2003, the treatment plan was very unique. It's not that unique anymore, and I think it's done quite a bit. So stage 3 covers, she was the B, there's also the A, and I think there's even a C now. I don't know. Let's talk a little bit about how we treat these patients.
Yeah, so stage 3 in general, so these are either very large or tumors that are abutting or involving things like the aorta, or tumors that have mediastinal lymph nodes, sort of lymph nodes in the center of the chest. And though I'm so happy to hear that your mom was able to get this very involved surgical approach and did so well with it, in general, like those are actually considered inoperable. And the benefit for surgery is more case by case.
Yeah.
And
Sure,
your
sure,
mom
sure.
had a great case.
Yeah.
In general, these have been treated with chemoradiation. This is again the multidisciplinary approach. This is a combination of radiation therapy. Since we're treating tumor and lymph nodes, this would not be appropriate for a short course like stereotactic body radiation, which is ablative. We can't ablate the center of the chest with the spinal cord, heart, esophagus. We need to break up the tumor dose into many small doses. It's typically 6 to 7 weeks of daily radiation. And we incorporate chemotherapy. The chemotherapy serves a couple purposes. One, it's systemic. These are tumors that may have the chance to spread. But the real benefit of chemotherapy in the context of stage 3 is actually that it's radiosensitizing. In other words, it makes the cancer cells more sensitive to radiation. And usually the medical oncologist and the radiation oncologist are collaborating closely. Drugs that you may have heard in the context would be carboplatin and Taxol, cisplatin and etoposide, plus radiation. And that's how this has been treated for about 20 years. Turning the page to sort of 21st century really advanced oncology is the incorporation of immuno-oncology into this treatment. So there's a trial called the Pacific trial that compared patients being treated in the exact way described, what we call platinum doublet plus 60 gray of radiation over 6 weeks alone. And historically that's been associated with a 5-year overall survival, about like 25 to 35%. So good, but room for improvement, versus that same program followed by 12 months of immunotherapy, in this case, durvalumab, okay? The results are very impressive. So the 5-year overall survival was improved by 10%. So it went from about a 33% overall survival at 5 years with just chemoradiation to a 43% 5-year overall survival. So that's exciting. That's incorporating sort of the latest of cancer medicine, immuno-oncology, with what's been the backbone for many years, traditional chemotherapy and radiation. There's some interesting interplays between radiation and its ability to cause rapid cell death and therefore expose the immune system to the proteins, what we call the tumor antigens. And maybe there's some interesting synergistic effects that go in both directions of the immunotherapy, making the radiation work better, and by exposing the immune system to these tumor antigens and the immunotherapy sort of ramping up the immune system, that there's some interesting interplays there as well, which is why we see that, you know, a 10% overall survival benefit in the world of oncology is huge.
Yeah.
Yeah.
So we talked about chemo and we talked about IO, immunotherapy. Does it work similarly with targeted therapy?
So there wouldn't be that same like immunologic synergy. It's been known for a long time that radiation actually ramps up the immune system and can create these interesting immune effects. It's called the abscopal effect, where like usually when we treat radiation, we consider just a local therapy, but sometimes it's hard to predict when it happens. It triggers a more broad immune response. And that's a lot more likely when you're incorporating immunotherapy.
Sure.
Yeah, and targeted therapy just wouldn't really have that. Yeah.
Okay, that makes sense. So let's talk about radiation therapy and stage 4. And I want to preface this by saying a lot of times I'll talk to folks, and this isn't maybe not even I'll talk to folks who are like, well, why can't they just radiate? I got that big fat primary tumor. Why don't they just get rid of that and maybe all the other ones will follow with the systemic, right? There's this sort of like logic concept that happens to it. So why is that not effective, and why do you tell people no?
Yeah.
And what is effective, and what are we doing in stage 4 right now?
I so wish it worked that way. There was like the primary tumor was like the mothership, and then you sort of took out the mothership, and there's some, you know, rogue, you know, troops that after a matter of time they're going to wither away without the support. But you know, with cancer, like it really only takes one cell to be its independent clone and grow a new tumor and then propagate cells elsewhere. So radiation alone, once cancer spread from its original site to another site of the body, what we call metastatic disease or stage 4 disease, really isn't the right tool. We need a systemic therapy like chemotherapy, immuno-oncology, targeted therapies to really wash the body over and treat all the sites simultaneously, as well as the microscopic sites that haven't shown up on a scan yet, and therefore sort of prevent new spots from showing up. It doesn't mean there's no role for radiation therapy. If you want to walk through some of those, we can go through it. Yeah. Okay, so like, again, lung cancer, you correctly state, often does go to the brain. Again, the track record of traditional drug therapies entering the brain has not been as reliable as it is today. Now there's some great options, Tagrisso, alectinib, entrectinib. I mean, like depending on your driver mutation, you're likely to find one. But in general, if the tumor is growing, we're going to either surgically resect it, but more typically use what's called stereotactic radiosurgery, where we're delivering really high doses. And what helps is that actually, if a cancer goes into the brain, it doesn't actually infiltrate the brain. It tends to generally like push the normal brain out of the way. So we can just target the tumor, avoid the normal brain, and as the tumor melts away, the normal brain sort of reoccupies that space. And that could be done these days in many cases just one session to treat. I mean, I think our institutional record is like more than 20 metastases in one session. And if more needed, more needed. So that's in the brain. Now, elsewhere in the body, again, we talked about the oligoprogression scenario where a patient's on systemic therapy or not on systemic therapy, and 1, 3, 5 tumors start growing. We can stay the course with that systemic therapy and just pick off those biologically bad actors with stereotactic body radiation. And then there's also sort of the what we call oligometastasis, where they're even at diagnosis, there's just a few spots, 1 to 3, 1 to 5 spots. There's actually a clinical trial done called the SABRE-COMET trial that included types of cancer other than non-small cell lung cancer, but many of the patients were non-small cell lung cancer. And what this trial did was it took patients and they had the medical oncologist give whatever the best standard of care, state-of-the-art systemic therapies, be it targeted, be it immunotherapy, be it chemotherapy, to treat the system. And according to the old paradigm, that's all that should have been done. And that radiation shouldn't have really made much of a difference because the reason why chemotherapy or systemic therapies make patients live longer is it prevents new spots from showing up. So they randomized one group to get best systemic therapy to the judgment of the medical oncologist, and the other group to get same principle, the best systemic therapy, plus use stereotactic body radiation to treat up to 5 spots. And you'd think that maybe, okay, you'd control those 5 spots, but what difference would it really make to survival? And actually the 5-year overall survival in the patients who got the radiation was 43% versus like 13% in the patients who just got the drug therapy. So actually, by being aggressive locally in oligometastatic disease with non-small cell lung cancer and a few other types, not all types of cancer, you really make patients live longer. So it's not just perpetuating the ability to give the drugs. It's not just controlling spots and making scans look better. It's a dramatic improvement. And this type of trial has been replicated in other ways, but the SABRE-COMET trial is really the one to know at the tip of the tongue.
Yeah, and I think it's things like that make me so excited about the future of cancer treatment and the role that radiation therapy plays. And also, again, to all of you in the room who know, I see you there. But I do definitely want you to talk to your healthcare providers about when and why a clinical trial might be right for you. And this is a perfect example. Mm-hmm. So sometimes cancer can get into places that cause great pain or. Can we talk a little bit about how it's used maybe first explain palliative and then.
Yeah, so now we're transitioning away from like the curative or oligometastatic situation. Though, to your point there, the stereotactic body radiation can be used to palliate pain as well. But let's just say that this is a situation where we're using radiation really just to control symptoms. I mean, that's what we call palliative. Palliative is not the same as hospice. Palliative is not the same as comfort care. Palliative is really addressing symptoms. So we're not doing this to make patients live longer. We're not doing this for the oligoprogression situation. We're doing this because a tumor is causing a symptom, usually because it's compressing into something, and we're going to use focused radiation to sort of relieve that compression. So common sites for this would be tumor growing in the bone. Bone is not cement. The outer layer of the bone is made of what's called periosteum, which is really richly innervated. And a tumor that's growing into that can be quite painful. We can use radiation to alleviate that pain. It works beautifully. Tumors hemorrhage. So tumors in the context of lung cancer that are in the bronchus, they can be causing bleeding and coughing up blood. Radiation works beautifully to end that hemorrhage. Tumors that are knuckling into neurologic structures like the spinal cord, we can use radiation to alleviate that pressure, and that can turn near paralysis into full function. Tumors that are knuckling into blood vessels, and in the context of lung cancer, there's a blood vessel called the superior vena cava, which drains the blood from the head. This is a scenario where we can use radiation to sort of keep that patent and open so that the blood flows back to the heart without obstruction. These are just some examples of how we use radiation for palliation. Really, this applies across the field of medicine to almost any tumor type.
I do want to cover side effects, if that's okay. Talk a little bit about what people can expect during and post therapy.
Yeah. I mean, radiation does have side effects. I think anyone who's gone through radiation has had at least some side effects. And it really has to do with where we treat. So side effects in the lung versus the brain are different, but just to focus on the thorax and the lung, anyone going through a course of radiation will usually have some degree of fatigue. The fatigue with radiation is not quite like chemo. It's not like getting sick with radiation. It tends to be more of like a late in the day, feeling more tired, like almost like if you had a big day. That's something you can really expect, and that would go away after the treatment's done. When we're treating in the lung, your radiation oncologist actually should be able to predict, not at the first handshake, but before they start the treatment, what the likelihood of radiation causing damage to the lung that would be noticeable with shortness of breath or cough. That's called radiation pneumonitis. Or once that process sort of burns itself out, scar tissue in the lung called fibrosis. And especially like symptomatic, like to the point that a patient would notice a change in their breathing. And usually that should be very low risk. And if the radiation oncologist were to be asked, and that's a very fair question to ask, usually we'd like to keep that less than 5%. If the tumor is close to the esophagus, because that esophagus runs through the center of the chest, then there could be a risk of like sort of a heartburn sensation, what we call esophagitis. That's really common when we're treating the lymph nodes, because the lymph nodes are right around the esophagus. And then, if the tumors are close to the chest wall, there could be risk of damage to the chest wall, or even in some cases, rib fracture. And I mean, I don't think you have to go too far to have met some people who've had some of these side effects. They're real. Sometimes they're very rare, like the rib fracture is really rare, but if you see enough patients, you'll see it. And the advice to the radiation oncologists out there is listen to your patients. If they're telling you something, listen to them. It's how you learn. It's how you identify the 1 in 1,000 toxicities. But those are sort of the big ones to touch on.
Yeah, and I think the esophagus, the food tube, right, so is a big one, because sometimes it can cause you not only some of the vocal cords and laryngitis and things like that, but trouble swallowing and eating and drinking and that type of thing. And again, this is where palliative or supportive care can come into play, and having these conversations with your healthcare provider about these side effects in real time to get ahead of it so you're not behind it is so incredibly important, because there are tools and tricks out there to help support through some of these side effects.
In the multidisciplinary approach, one of those approaches would be eating organics and having vitamins and minerals and so on. When you get radiation, are there any of those types of things you have to avoid, or does that not figure into the equation at all?
Yeah, no, that's a great question. I mean, actually one of my areas of great interest is sort of like lifestyle medicine, like what can we do in sort of the wellness realm to make our cancer treatment go better. I will say that there's very few like real concrete guidelines. So as far as like diet, I actually advocate for a plant-forward diet, like not necessarily vegan, but really having like 5 to 8 servings of fruits and vegetables a day. And like a serving is about the size of your fist. So like an entree salad isn't 1 serving, that could be 5 servings, depending on the size. And then a good source of protein, again, doesn't have to be vegan, but I mean, there are good plant sources of protein and beyond. As far as like things not to do during radiation, really during cancer treatment in general, I think weight loss needs to be avoided. Across all cancer types, like a weight loss of more than 10 to 20% of the initial body weight is a negative prognostic factor. So people who go too extreme with things like juicing or something like that, I mean, juice is great, fine, go for it. But really who are eliminating so much that weight loss is alarming, that's typically counterproductive. And then as far as like specific things during radiation, there's a theoretical interaction between high dose vitamin A, C, and E in radiation that's actually not helpful. So we usually advise patients to hold off on like high dose vitamin A, C, or E, like the kind you'd see like if you got like 1,000 milligrams of vitamin C, like that's a normal supplement you'd find at Safeway or any pharmacy. That has like 1,500% of the daily recommended allowance. Like you don't need that. Rather get those antioxidants through those 5 to 8 servings of fruits and vegetables, and you'll be good. Yeah.
So I want to close out tonight with, what do you most hope people take away from this conversation tonight?
Yeah, so number one, if radiation is brought up, in the context of your recommendations. It is very safe. It's very targeted these days. It's not getting nuked by any means. It can play a role across the full spectrum of lung cancer presentation stages. And go with a team of doctors or a radiation oncologist who you trust based on the conversation you have with them, with the sort of openness and transparency of how they're making their decisions. The reason I'm making the decision should be very understandable to the patient, because it should make sense. And then from there, it'll all be taken care of. Yeah.
I love that. I cannot thank you enough for coming and for staying longer than I asked you to, or we asked you to answer some of these questions that I know are going to be helpful not only to the people watching tonight or here tonight, but those who are going to come back and watch it later. So thank you, thank you, thank you, thank you, thank you.
Thank you.
So I know Genevieve said she wasn't on it, so I do want to remind everybody, if you're not on it and you would like to be, there's absolutely no pressure. But sometimes the third Tuesday of every month comes around real fast and we forget. So we've launched a text service last month to remind folks about this programming. You just have to text the word living room, all one word, to 844-871-7558. That information is also available on our website on the living room page. So you can get that information there as well. You can actually stop it at any time if all of a sudden you're annoyed that we're reminding you. Just text stop and it'll stop texting you. I want to say again, thank you to Dr. Schiffner for coming and talking. I know we've been, like I said at the beginning of this programming, poking you for a while to get here, and we could honestly
blame it on COVID.
We could, we could not be more grateful that you came and spoke tonight. All of you in the room, all of you watching live or post live, thank you. Thank you, Penn Media, for coming in here early afternoon, the third Tuesday of every month, and setting all of this stuff up for us. Onyx and Ash, and then of course, Michelle Zay and the GO2 staff for all the support that they give to this programming. Very, very, very last thing is all of our supporters. Amgen, AstraZeneca, Bayer, Boehringer Ingelheim, Bristol Myers Squibb, Daiichi Sankyo, Eisai, Foundation Medicine, Genentech, Johnson & Johnson, Merck, Mirati Therapeutics, Novartis, Novocure, Regeneron, Sanofi, Takeda Oncology. Thank you, thank you, thank you for your ongoing support of this very important programming. And thanks for coming, everybody.
So I'll be brave if you're brave. I'll be brave, but only if you're